All right, today we are focusing on a really critical technique in neurosurgery, the advanced scalp block. We're going to walk through everything from the key anatomical landmarks to the precise way it's done and really get into why it makes such a huge difference for patient safety. Let's get started.
It seems like a simple question, but the scalp is one of the most sensitive and blood-rich areas of the entire body. The stimulation from just applying skull pins or making an incision, well, it can trigger a massive physiological stress response. So the real question is, how do you disarm that response before it even has a chance to start?
So here's our game plan. We'll start with the why, the challenge of the pins. Then we'll look at the blueprint of the nerves we need to map. After that, we'll get into the execution, a real step-by-step guide. We'll cover the precision techniques that make all the difference, and finally, wrap up with the payoff for the patient.
Okay, let's dive right into the why. Why is this procedure so incredibly important? It really all comes down to one thing: controlling the body's powerful and potentially dangerous reaction to the start of surgery.
Think about it. Applying that head fixation device and making the first cut are intensely stimulating events. They can cause a sudden, really dangerous spike in heart rate and blood pressure, a powerful hemodynamic response. Now, for a patient with a brain injury, or for someone whose brain can't properly regulate its own blood flow, a condition we call impaired cerebral autoregulation, that kind of surge can be catastrophic. The risk is a dangerous increase in pressure right inside the skull.
So, to prevent that response, you need a very precise plan. And that plan is built on a detailed anatomical map. A successful block isn't just about injecting medication randomly. It's about systematically and accurately targeting every single nerve that provides sensation to the scalp. And this diagram lays out our targets beautifully. The front half of the scalp, basically everything in front of the ears, is covered by branches of the trigeminal nerve. You can see V1, V2, and V3 there. The back half, that's supplied by branches from the cervical spinal nerves, mostly C2 and C3. Understanding this anatomical split, that is the absolute key to pulling off a complete, successful block.
So here they are, the 6 specific nerves we need to intercept to create this complete ring of anesthesia. Up front, we're targeting the supraorbital and supratrochlear nerves from V1, the zygomaticotemporal from V2, and the auriculotemporal from V3. Then in the back, we're going for the greater and lesser occipital nerves, which stem from the cervical spine. Now that we've got our map, let's see how it's done.
Okay, with that anatomical map clear in our minds, we can move on to the procedure itself. We're going to build this anesthetic shield around the head in 2 main phases, starting at the front and then working our way around to the back. So, phase 1, our first goal is to build the front half of our anesthetic shield, and we're going to do this by targeting those very specific branches of the trigeminal nerve that we just identified on our map. This image shows our first injection point perfectly. The key landmark here for both the supraorbital and supratrochlear nerves is something called the supraorbital notch. It's a little groove you can actually feel along the upper rim of the eye socket. A really precise injection right here is the first pillar of our anterior block. So let's run through a quick mental checklist for the front. We start at that supraorbital notch for our first 2 nerves. Then, we just move a bit to the side, to the temple, and identify the outer edge of the orbit for the zygomaticotemporal nerve. We wrap up the interior part by feeling for the zygomatic arch. That's your cheekbone, right in front of the ear. That's where we'll find the auriculotemporal nerve. Now, with the front of the scalp nicely anesthetized, we can shift our focus to the back. This is what completes our sensory shield, and it ensures we have full coverage for the entire surgical area. And here you can see the key landmarks for the posterior block. Our main target here is the greater occipital nerve. The most reliable way to find it is to first feel for the superior nuchal line, that's the horizontal ridge at the base of your skull, and then feel for the pulse of the occipital artery. The nerve sits just medial or a little closer to the midline than that pulse. So, to sum up the posterior approach, we find that occipital artery pulse to target the greater occipital nerve. Then we just move about 2.5 centimeters to the side, or lateral, from that point to block the lesser occipital nerve. Together, these injections basically create a complete wall of anesthesia all across the back of the head. All right, so performing this block effectively, it's not just about knowing where to stick the needle. Expert technique and a profound respect for patient safety are what really elevate this from just a simple procedure to a true clinical art form. Getting the anesthetic in exactly the right spot, the right anatomical plane, is absolutely critical. Our target is a specific layer called the subgaleal space.
It's a layer of loose tissue where all these nerves travel before they fan out. An experienced clinician can actually feel a distinct tactile pop as the needle passes through the tough galea layer just above it. That pop is the confirmation that you're in the perfect spot for the anesthetic to spread effectively.
So let's break down what's often called the consultant's technique. It's all about a few key refinements. First, using a fine 25-gauge needle gives you incredible precision. Second, instead of just 6 separate injections, you create a bridge infiltration. You're basically connecting the dots with a continuous line of anesthetic to make sure no little nerve branches are missed. And most importantly, safety. The scalp has a ton of blood vessels, so you have to aspirate, that means pulling back on the plunger, every half a milliliter or so to make absolutely sure you haven't accidentally entered a blood vessel.
The choice of medication here is also key. You want a high volume of a long-acting local anesthetic, something like bupivacaine or ropivacaine, to make sure you get widespread coverage. And it's mixed with a little bit of epinephrine, which does 2 crucial things. It constricts the blood vessels to make the block last much longer, and it also acts as a safety marker if you were to accidentally inject it into the bloodstream.
So, we've covered the why, the what, and the how. But what does all of this meticulous work actually mean for the patient on the operating table? What's the real-world payoff here?
Well, the block takes about 10 to 15 minutes to really take full effect. And this timing is a huge advantage. It allows the team to perform the block very early on. So by the time the patient is fully positioned and prepped for surgery, their scalp is completely numb. This means we prevent that dangerous hemodynamic response right from the get-go, right from the most stimulating part of the procedure, the skull pin placement. And honestly, the difference in the patient's outcome is like night and day. Without a block, you can get hemodynamic instability, you need deeper general anesthesia, and you see significant pain after the operation. With the block, the patient has total stability, needs less general anesthetic, experiences far less pain, requires fewer opioids, and because of all that, wakes up with a much clearer head. The benefit is just profound.
This quote really puts it all into perspective, doesn't it? This isn't some brand new idea. It's the evolution of a century-old concept into a modern, precise technique that has fundamentally changed the game for safety and comfort in neurosurgery.
And that leaves us with a really fascinating thought to end on. We've seen how a precise regional block like this can dramatically reduce the need for heavy general anesthesia. So as these techniques get even more refined, could we be heading toward a future where targeted nerve blocks play an even bigger role, maybe even making general anesthesia obsolete for surgeries we can't even imagine doing that way today?